Okay, so I will start this panel discussion session. First, I would like to thank all the participants. Um, at this moment, we have Dr. Ronnie Fass, Dr. Tahir Homari, Dr. Mark Fox, Geoff Kahn, and we have Prakash Gyawali. We have Dr. Rami Suez and Dr. John Pandolfino. I am Daniel Sifrim, and I would like to thank all the panelists to um, the time that they will contribute to this discussion on the Lyon consensus on diagnosis of gastroesophageal reflux. Um, there are several questions that have been proposed for this panel. We will try to um, discuss most of them. I will ask the panelists to um, consider that they have 2 or 3 minutes to answer each of these questions, and then at the end we will have time, if possible, to have a kind of final conclusion. I will first would like to introduce Dr. Ronnie Fass. Dr. Fass was not involved initially in the Lyon consensus discussions, and I think that this is a very interesting opportunity to offer him the chance to discuss his viewpoint from outside the Lyon group and his opinion about some of the statements of the Lyon consensus. Uh, Ronnie, would you like to start, please?
So thank you very much, Daniel, and really thank you everybody for giving me the opportunity to serve as a co-chair and to be part of this panel discussion. Now, as Daniel mentioned, I was not a part of the Lyon consensus meeting, so that gives me as some kind of an objective point of view of, especially of the clinical practicality of these consensus recommendations. I've had some concerns about these recommendations. Obviously, some of them I felt that there is very little evidence to support them. But more disconcerting was the whole concept of conclusive and inconclusive. For example, if you take patients with erosive esophagitis and you put now those with grades A and B as inconclusive, that's about 70% of the patient with erosive esophagitis that used to have the diagnosis, and now they fall under the category of borderline and inconclusive. If you add also those that have normal endoscopy and they have total esophageal acid exposure time between 4 and 6% also as inconclusive or borderline, that also put the majority of patients with non-erosive reflux disease now under the category of it's not clear if they have the disease. So from a clinical point of view, one of the issues that I have, and I hope to discuss it today, that we will be able to discuss it, is the fact that if I am a clinician at this point, I find out that most of my patients that I knew that they have GERD now fall under the category of being borderline or inconclusive, and there's no really clear recommendations from the Lyon consensus. What should be the next step? Is PSPWI sufficient to make the diagnosis? Is MNBI sufficient to make the diagnosis? So how could we help the practicing physicians who some of them got somewhat confused from the Lyon consensus, help them to understand the consensus, the recommendations, and obviously, as was mentioned by Daniel, where we're going from here to Lyon 2. So I'd like to start with Prakash. Thank you very much for being here and giving me the opportunity to ask you a few questions. So I'd like to start with the first question. What for you is the key step forward from Porto to Lyon? Definition of conclusive and inconclusive diagnosis, and if you can also discuss what I mentioned as a potential critique. Integration of the test or something else?
Thank you, Ronnie. And these are valid concerns that you brought up. Just to give you a little bit of a background, the Lyon consensus process actually took place over a period of 3 years, from 2014 through 2017. And we had meetings at many of the DDWs and UEGs during that period of time. And the overwhelming opinions through these meetings was that we needed to have something on paper that established without a doubt what reflux evidence meant, so that these elements, the elements that we listed under conclusive, were actionable. If people had those elements, you could do something invasive to the patient and be okay with it, because there were conclusive evidence for reflux disease. So that's where that started. And the items that were listed under borderline were not enough to do something permanent to the patient. And I know LA grade B was part of a lot of contention at those meetings. LA grade A, obviously significant overlap with non-reflux asymptomatic volunteers, but LA grade B, there was a lot of contention. And what was concluded, or what was discussed during those meetings, was that the conclusion of LA grade A really depended on the expertise of the endoscopist, and that some LA grade Bs were probably As, and others might be Cs, and there was a lot of variability. Now, was that enough for somebody to just go ahead and wrap that patient or send them for invasive therapy? So we discussed this at length. And finally, the conclusion there was that you needed something beyond just LA grade B. And that could be a hernia, because if you see the next row of the Lyon consensus, a hernia detected on manometry falls into that category. So if you had LA grade A or B plus a hernia, you get to conclusive. The adjunctive evidence leads one to a conclusive diagnosis. So that was the process of getting to the borderline or inconclusive evidence. So each of those elements listed under the inconclusive evidence could get you to a conclusive level if you picked something from the next row, the supportive evidence row, that gave you additional confidence. Now, obviously, at that point in time, the MNBI and PSPW were rather new, and they got left in that category. So did some of the other elements there, like reflux symptom association, among others. And so, again, if you had borderline evidence and something from that next row, the discussion was that could get you to a conclusive level of evidence for reflux disease.
Let me further ask you related to this issue. So if you have a patient with 3 erosions at 3, 6, and 9, 5 centimeter each, no hernia, fall clearly under the category of grade B, would you still ask that the patient will undergo additional invasive tests to make the diagnosis? Because I'm raising an issue that I've heard many times, and it was brought up in many meetings, concerns about that. Would that patient now will have to undergo an invasive procedure, costly procedure, and sometimes the procedure is not even available?
So Ronnie, it really depends on who did the endoscopy. That's how we positioned this at that time. So if anybody on this panel endoscoped those patients, yes, that is good evidence for reflux disease. But if you get a report from the community saying that that was LA grade B, and you're sitting there making a decision about what the next step was going to be for the patient, the groups that participated in the Lyon consensus discussions felt that that wasn't enough. You needed it confirmed with additional, usually reflux monitoring at that time. And please feel free to chime in, because most of the others on the panel were at those discussions too.
Ronnie?
Okay, let me continue. Let me ask you, Prakash, another question. Should Lyon be regarded as evidence-based or expert-driven? Was the system in your mind robust? What statements are well supported? So I will not go through all the statements, but just want to think your opinion. What is the level of evidence-based and what is the level of expert-driven recommendations in your mind?
So it was never intended to be evidence-based. It was a combination of evidence plus expert opinion. Because if you just look at the level of evidence, we published this in 2017 with Sabine as the first author. The level of evidence for all of these thresholds was low. And one of our recommendations was that we needed outcome studies so that the next version, the next iteration of these guidelines would be more robust. But yes, it was always meant to be a combination of available evidence plus expert opinion. And so what we put out in the Lyon consensus was the conclusion through 6 or 7 of these meetings that we held at many different venues where a lot of different opinions were voted upon. Not necessarily in a Delphi method or a RAND method, but by discussion and consensus at these meetings.
Let me ask you a quick one. It's the last one. Is there a gold standard in your mind for GERD diagnosis? I'd like to say I have some aversion for the term gold standard, but at least I noticed that in the paper, it says the pH impedance is the gold standard for characterizing reflux. Is that something you consider the case?
So I think we're playing with words a little bit here. There is no gold standard for the diagnosis of reflux disease, but the pH impedance is thought to be the gold standard for the detection of reflux episodes, because that it does it better than any other technique that we have. For reflux episodes, yes, but that's the best we have. But not gold standard for the diagnosis of gastroesophageal reflux disease, at least in my mind.
Okay, thank you, Prakash. I'm going to turn to Daniel now.
So we will
I think that John would like to say something about the topic.
Edo, I will come to the techniques for diagnosis now, and you will have the opportunity to discuss this in a minute. So the next section is about the techniques, and I will focus mainly on 3 different possibilities. One is the catheter-based 24 hours pH impedance metry. 2 is the wireless prolonged pH metry. And 3 is the newcomer, the mucosal impedance measurements through the endoscope. So the first question for the people that was dealing with the techniques is, do you think that the Lyon, or at least the next iteration, should be much more specific about the clear selection of the techniques in different circumstances? In other words, when to use catheter-based pH impedance, when to use Bravo, when to use mucosal impedance. Do you have an idea or that can be improved for the next Lyon iteration?
Thank you, Daniel, for your question. I think that I was answering that I believe that for the next iteration of the Lyon consensus, there will be space also putting more details about the Bravo pH capsule and the setting where this kind of techniques could be better than the pH probe techniques. To be honest, I don't think that there is a lot of literature to suggest which one is the best for which setting, but we will try to make some efforts to produce some literature before doing the next version of the consensus, and probably also have some direct positioning of these different techniques for GERD management.
More focusing on the new impedance parameters that are discussed, at least proposed as adjuvant parameters in the Lyon, I mean the MNBI and the PSPW. The value of these two parameters in order to move one patient that is in the gray zone, the inconclusive zone, to either negative reflux or positive reflux disease. Do you think that they are strong enough at this moment with the for this task?
Thanks also for this question. I believe that for the baseline impedance, we have honestly enough data to support the use of it in clinical practice, because there are data based on pH impedance probe, based on also mucosal impedance through the scope probe that have some similarities in terms of cutoff values with the pH impedance probe baseline impedance. And also there are also outcome data from St. Louis and also other research groups that provided this data to suggest that baseline impedance may predict the outcome when you would treat the patient with PPIs, and fewer retrospective studies also with fundoplication. Of course, there are randomized prospective control studies to suggest that, but for instance, we believe that for baselines, at least there are some good data to suggest data, particularly outcome data to suggest its use. Mainly the data are available in medical literature are from Italian groups and also from London, from St. Louis, and from some groups also from Asia. But more robust data probably will be necessary to propose it in clinical practice, particularly if we consider that the analysis is not so easy manually, and we need probably some help from software and from the companies to improve the automatic detection of them to be used in widespread clinical practice.
One question related to these two new parameters. They are very much related to the level of acid exposure. So a patient with high acid exposure is likely to have low baseline impedance and low PSPW. So how common is that patients with a normal acid exposure have abnormal MNBI and PSPW? How common is that?
Not really so strictly related only to acid exposure time. Baseline impedance for sure. If the higher is the level of esophageal acid exposure, lower is the value of baseline impedance. But there are also data in patient study on PPI therapy which showed us that also weakly acidic reflux is able to reduce the baseline impedance to impair the mucosal integrity as well as acid exposure does. Of course, most of the studies are done off PPI therapy, so Daniel, most of the data are from studies in patients evaluated off PPI therapy, and so the evidence is there. For the PSPW, I do not agree totally with you, because the PSPW is impaired in patients with GERD independently from the acid exposure time, and there are retrospective data, of course, but from prospective collected patients that patient both on PPI, off PPI, and evidence on GERD based on a positive response to PPI or a positive response to fundoplication have an impairment of PSPW. So I think that, of course, the acidity of the esophagus plays a major role, but is not the only main factor leading to the positivity of these two tests.
I have one question which is very controversial, And I would like to ask you and John, if he's around, about the advantages and disadvantages of measuring MNBI with a catheter-based reflux monitoring technique over a prolonged period compared to the mucosal impedance technique that is an instant measure through the scope. Do you have a position about this?
So Prakash can also, I guess, talk to this point, as we've been involved in now, I guess, our fourth year of doing a simultaneous mucosal integrity assessment compared to wireless capsule pH and also pH impedance on PPI therapy. And we're in the middle of this study, and you know, we've done some interim analysis, and it's actually a very different probe than the through the scope probe. It's actually a separate entity catheter that is passed alongside the scope or the scope in place while you're actually inflating a balloon and looking at mucosal integrity. And I think the jury's still out. I don't think we have good enough data yet to make you know, any claims regarding its predictability of disease state, but we are seeing, you know, a distinct population of people with normal acid exposure that actually do have a lower mucosal integrity that may represent maybe this low tissue resistance variant that have a hypersensitivity to physiologic stimuli. But I think we're a little bit early, and we haven't looked critically at the data enough, certainly from that study. Prakash, I don't know if you have anything to add.
Yeah, it does seem that in some patients we are measuring something different from acid exposure, but I think it still needs to be teased out and determined if that has any management implications or outcome value. But more to come on this. I think we'll know more in a year or two as this study moves forwards.
I am the chairman of this session, but I would like to say what I think, if you don't mind. And I'm sorry for this dictatorial attitude. I think that the mucosal integrity evaluation with the scope is a very interesting tool to define the status of the mucosa, and probably is very helpful for diagnosis of mucosal damage, whatever it is. However, it does not tell us anything about hypersensitivity, and it doesn't tell us anything about gas related symptoms, rumination related symptoms. So I think that the indications for the two techniques should be better identified according to the symptoms of the patient or our suspicions of what is going on. I don't think that the mucosal integrity technique will replace the other. They will work in parallel. For some cases, one is better than the other and vice versa. So I'm sorry for this comment, and we can move forward now to the next questions that Ronnie will ask to the surgeons.
Yeah, I wanted to take the liberty also to comment on your last question as the co-chair. And I just want to comment that if you ask Mike, what is the difference? In his feeling is that when you have the mucosal impedance, you get a better contact between the sensors and the esophageal mucosa. So in his mind, you get more accurate measurements as compared to the NBI, which you get a great variation in measurements. And also, it's not clear really if you should measure it only at 1, 2, and 3 o'clock in the morning, because if you look, the variations in NBI during the sleep period actually follow the variations in esophageal acid exposure. So they are higher at the beginning of sleep and they are lower at the end, towards the end of sleep. So this is my comment on this discussion. I see, Eduardo, you want to comment on that.
Of course, I quite disagree on what you said. There is a study done by Daniel comparing the entire nocturnal period as compared to the mean nocturnal baseline impedance, and the correlation between the two measurements was almost perfect. Daniel, if you can say something about that. And so I'm not sure that is so variable also during nighttime, apart from diurnal time.
But I think that the measurement over a long period, average the values of mucosal impedance, and I think that is a good representation of what is going on in the mucosa in a subject. What I am still waiting from Michael and others doing the mucosal integrity test is a pair comparison of measurements in the same subject, in a large group of subjects. What is the MNBI and what is the mucosal integrity? And if they are giving the same results and making the same diagnosis, then there is no advantage. So I think that in the study that John was mentioning and Prakash, you can know that. How do they match in terms of, not on absolute values, but in terms of diagnosis? So we will know that. Concerning the next question, Ronnie, I think that you were going to start.
So I think let's move, and I'd like to ask Jeff a few questions. The first
Could I ask a question? Sorry, I had my hand up. Sorry to butt in. There is, of course, another mucosal integrity test, and that is high resolution manometry with impedance. And some of these data that you're looking for in terms of the mucosal impedance balloon versus MNBI, so forth, those data are emerging in the context of high resolution manometry impedance, specifically this parameter contractile segment impedance, where there is evidence to show that there is a fairly strong correlation between mucosal impedance measured with that methodology and the MNBI. Indeed, a paper just came out in Neurogastroenterology and Motility this month, showing fairly strong correlation. So the manometry and where it sits is somewhere in between. It's in the zone between these modalities, and it can perhaps answer some questions that both provide.
Okay.
Okay, thanks, Daniel. So the first question for you, Jeff: should patient with reflux hypersensitivity still be sent to surgery, in your mind?
It's a difficult question. Let me take one step back. Your concerns about Lyon were very insightful, talking about the definitive or conclusive versus non-conclusive GERD. But from a surgeon, things are a little bit different, I think. What we want to know is whether our operation is going to work. So patients either are going to have an operation or not going to have an operation. So we deal with more of the extremes. A lot of this talk, at least in my mind, of PSPWs and MNBIs at the moment, really don't have correlates or outcome data after fundoplication. So my role tends to be a little bit easier. If there's not a clear benefit to be achieved by fundoplication or other anti-reflux operation, I'd normally try to stay away from surgery until all other avenues have been exhausted. Hypersensitivity fits into this area quite nicely. Operating on somebody whose symptoms are solely due to hypersensitivity, with not much in the way of abnormal acid exposure, doesn't tend to go as well. We don't have the data to support, or don't have rigorous data to support good outcomes after fundoplication for this group. So I think surgery would be a long way down the list after an extensive trial of other modalities before even considering it.
So what is more important to treatment outcome after anti-reflux surgery? Is it preoperative tests and patient selection? Is it the choice of the surgical procedure and looking at Nissen versus all the partial fundoplications that are available? Or is it the technical proficiency of the performing surgeon?
You've given 3 options there. I think 1 and 3 are probably the most important. 2 is probably the least. Preoperative diagnosis is everything. Again, we have conclusive and inconclusive GERD. But what we really want to know is who's going to do well from an operation and who isn't. So the 2 extremes are easy to define. It's the middle ground that's more difficult, and they're probably the ones we wouldn't be rushing into an operation anyway. So people with grossly elevated distal esophageal acid exposure with high impedance levels in a young male with good symptoms of typical reflux, we know they're going to do well. When you start decreasing that, the outcomes are less likely to be positive. Certainly, there's no great data to support tailoring of the RAP. You mentioned different types of fundoplication. Depends where you're trained and where you practice, really depends on the type of fundoplication you're likely to perform. But the data really is not very supportive of tailoring the RAP according to motility outcomes or the like. Magnetic sphincter augmentation throws a little bit into the mix there. The thought is, as you know, that one operation or reflux is not the same in everybody, and the severity of the reflux is not the same in everybody, and perhaps tailoring the extent of the lower esophageal sphincter operation via different techniques may make a difference. Again, that depends on where you're practicing. MSA is taken up more in certain parts of the world than others, but certainly based on preoperative manometry is probably not so helpful. Technique is always important. It's not such a difficult operation. I'll tell you a secret. It's not such a difficult operation. There's many different ways of doing it. Most of the outcomes for people who know what they're doing and do large numbers are very good in appropriately selected patients. And the techniques among those groups are widely varied. So I don't think it makes a huge difference. And indeed, we're not 100% sure, are we, and exactly how the fundoplication works. So we don't know exactly what we're aiming to achieve anyway. We want to increase the anti-reflux barrier, we don't want to cause complications, and we want to make it durable. And all of those points are a little unknown. So a long answer to your very good question. I think that preoperative diagnosis is important. Technique is quite important, and selection of the appropriate operation is probably least important of those 3.
Ronnie, can I ask Geoff something?
Yes, sir.
How did the Lyon consensus affect the surgical reflux world? Did it have any impact?
It made things a little easier. It defined to us the severe refluxes. By including, say, Los Angeles B in inconclusive, that means we've left with C and D that are more severe refluxes are more likely to respond to fundoplication. So it perhaps broadened that intermediate group, but very well defined the 2 extremes, I think. And perhaps what Dr. Fass may have caused an area of concern was quite helpful in giving us the information of those extremes that would be most likely to benefit from operation. With regards to PSPWs and MNBIs, at least in my practice in our area of the world, that hasn't been taken up so much yet in terms of the surgical sphere.
Let me ask you one more question. So there are various measurements that show prognostic value in patients that are considered for anti-reflux surgery, such as acid exposure, reflux symptom association, the presence of ineffective motility. So which do you consider as the most important? I give you just a few examples.
For sure. From my training, it's clearly, for me, the pH measurements on the 24-hour ambulatory pH, maybe with increased sensitivity on extending that period out to say 48 hours. Lyon quite nicely and previous iterations have explained that these tests should be performed off PPI medication to assess the baseline preoperatively, and I think that's very reasonable, and I think that's widely performed. We all agree that impedance increases the sensitivity of a pH test. How that translates into actionable data is more difficult. For the atypical symptoms of laryngopharyngeal reflux, reliance solely on impedance does not, in my opinion, seem to work so well in terms of post-operative outcomes. You gave me another few options on preoperative assessment other than pH. A manometry, preoperative manometry.
Yeah, so preoperative manometry. Ineffective esophageal motility.
Well, I do it on everybody. Many surgeons do not. And as previously mentioned, tailoring the wrap or changing the operation based on ineffective motility has been shown not to be helpful. We all know that there's improvements in motility after control of reflux. And as long as one's not doing say a Nissen fundoplication in someone with frank achalasia, I'm not necessarily sure the preoperative prognostic value of manometry, though it is very helpful in managing the post-operative dysphagic patient.
Could I just butt in there and ask Prakash to come back on this point, because of course he has done some studies which might challenge your perspective.
I agree.
I'm not sure about challenge, but I think our data was mainly collected in a retrospective fashion. But we were able to show that patients who did not have the ability to augment their esophageal contraction during stress, so during a physiologic provocative maneuver, were the ones who were most likely to have post-fundoplication dysphagia. So within patients with ineffective esophageal motility, if they were able to augment their contraction during a provocative maneuver, their likelihood of having post-fundoplication dysphagia was much lower than those that could not augment their contraction. In some ways, Jeff is talking about that very fact, that some patients with reflux disease and ineffective motility augment their contraction after anti-reflux surgery. And I believe those are the ones who have contraction reserve. And the remainder tend to have transit issues afterwards. Now, whether adjusting the wrap mitigates that, again, the older data suggests maybe not, but remember those studies, those motility studies that were reviewed as part of those older studies was conventional manometry, not really high resolution manometry. Now, one other point, ineffective motility was a very diffuse category until just recently. And it's only now that the criteria have been tightened significantly that only the people with the most profound ineffective motility are now termed ineffective motility. So it remains to be seen if the new ineffective motility category performs differently from the old, more diffuse ineffective patients.
If I may, the data on the ineffective motility is very heterogeneous, and so is the operation. In times past, Nissen fundoplication was more commonly performed than, say, some of the partial wraps, particularly in North American data. And indeed, even the fundoplication has changed from early on being quite a tight, I guess, overly tight wrap to these days the short, floppy Nissen fundoplication. Things have changed, so it is difficult on the retrospective data, particularly with the move away from complete fundoplication in many centres at the moment to compare.
So I see Eduardo and Rami wants to make some comments. So if, because of our time, if each one of you can make a short comment, please. So Eduardo, go ahead.
Thank you, Ronnie. I'd like just to know if the paper of Speckler published on New England Journal of Medicine about the role of food application in patients with the positive pH impedance changed your practice in some way.
That's me. I missed that question. I'm sorry.
If the paper of Speckler published on New England Journal of Medicine, the randomized controlled trial in patients with positive pH impedance testing, changed in some way your practice?
Yes and no. First of all, impedance pH is difficult to access in my area of the world. I do it reasonably routinely. And in my small practice, nothing compared to these series that are published, impedance numbers are not that helpful. Because these are a difficult patient population. There's a lot of other issues going on in many of the patients with the atypical symptoms of reflux. I don't think it's all necessarily due to the reflux, and people don't necessarily have to have one diagnosis. As in other chronic disease states, there are a lot of psychological overlays and issues. His data was very good. His series is very large and much larger than mine. But if you're asking, has the impedance grossly changed practice down here? Probably not, actually. We're still mainly based on simple pH data, even though I very much recognize the importance of the impedance analysis as well.
I see, Rami, if you have a question or comment.
Thanks, thanks, Ronnie. I agree with Jeff in that his apprehension about operating on patients who are in the inconclusive bracket, and instead of trying to tease the inclusive group by looking at these other various parameters, one area where Lyon perhaps falls short of is doesn't emphasize the importance of repeating the test. And if you repeat the test and you have again another inconclusive result, that means that you have two tests without a conclusive result. And in that context, it would give me more impetus not to operate, as opposed to finding at least one of these tests as being conclusive. You know, the conclusive result is the gold, if I'm going to use the word gold standard, is a better decider between whether to operate or not, rather than teasing between MNBI and OGJCI and symptom association, etc. That's at least my perspective.
Thank you. Go ahead, Daniel.
I think that we need to move forward. I wanted to discuss now with Taher the role of the new AIM analysis in if it can help in the diagnosis of reflux disease. This is a session on diagnosis of reflux disease, but also if it is possible to identify motility related or flow or emptying related factors that you can find with AIM and we cannot see with conventional HRM and MII-PH that can be of help, for example, to identify conclusive from inconclusive GERD patients or patients that might need a different type of surgery. Taher?
Yeah, thank you, Daniel, for the question. In fact, I was about to pipe in at the end of the last round of comments to say, please don't give up on manometry as a potential predictor of reflux and predictor of outcomes. I mean, clearly manometry does have a role in preoperative assessment. And the thing is that the studies that have been done so far are very, very much limited to looking at pressure phenomena. And I think what we can get now, and I think it's fairly clear from our data at least, that most of the data I'm looking at is pediatric data, but nevertheless, in addition to the changes in contractility that are well characterized in the EGJ and the esophageal body, we do see other changes that appear to manifest in patients with non-erosive reflux disease as a group. So, for example, increased bolus residual, reduced a shorter period of emptying of the esophagus and a change in the mucosal integrity as measured by mucosal impedance. So by adding impedance to the mix, we're getting a lot of other markers that potentially signal a propulsive disorder that may be consistent with a diagnosis of reflux disease or potentially predictive of a hopefully successful outcome with anti-reflux surgery. So I do feel that in terms of reflux disease and manometry with impedance, we still have a fair amount to discover. And I think there are a number of, what I like to call next generation type approaches. We've been looking at some ways of analysing data, as have other groups. And I think this is definitely something that's going to change in the next few years in terms of evidence that of additional markers of reflux that can be measured during a manometry study.
Is it possible that there is an equivalent in bolus abnormalities to the peristaltic reserve that Prakash describes with the after MRS contraction? In other words, that there is a kind of signature on the bolus abnormality, bolus transport abnormality related to this peristaltic reserve that happens after the multiple rapid swallows. And perhaps that bolus abnormality is a good predictor of postoperative dysphagia, as good as the peristaltic reserve.
I think it is possible to, can honestly say we don't have the data. I don't have the data yet. We're starting to collect data where we have obviously multiple rapid swallow data as well as data from individual swallows. And importantly, if we're talking about the bolus domain, we need to start thinking about using a viscous bolus, which is certainly we believe produces a much better bolus signature for these more sort of analytical approaches to try to tease out the inhibitory mechanisms that are governing bolus flow. So, but in terms of reflux disease, you actually have potentially more inhibition than so that may have some knock-on effect in terms of the bolus flow pattern that you see and the distension pressures and timing of flow. But we have published some very, studies about a decade ago that did pick up some changes in flow timing and distension pressure, and that were apparently predictive of reflux disease. And I believe they very much fit with the data in terms of abnormal multiple rapid swallow tests in terms of detecting descending inhibition. So if you have impaired descending inhibition, then perhaps that may be a predictor of a poor outcome, because impaired descending inhibition is not necessarily consistent with reflux disease. And so I think these various disparate observations do fit together in a model which has reflux disease at one end and perhaps dysphagia at the other. But we don't have the answers yet, I guess is the short conclusion to my comment.
Thank you. I have one of the last but very provocative questions for John Pandolfino. And it is a short question. John, is the future of esophageal testing in the endoscopy suite?
Well, I mean, I'm obviously biased, and I will tell you that I feel that it provides you with a completely different look. It's a stress test for the esophagus. You distend the wall and you see what happens. And that's really what the esophagus job is. It's to react to a volumetric distension. And whether it's a threat from below or a threat from above, It needs to move the bolus into the stomach. And I think that's what FLIP does in a very efficient and effective way. Now, I think it's very different than primary peristalsis. But, you know, if you look at some of the earlier work from Richard Holloway, yourself, I mean, secondary peristalsis is an important component of function. And to date, we really haven't had a good mechanism to evaluate it. And I think that's what we get with FLIP. So time will tell. You know, we have some preliminary data to support that it tracks okay with acid exposure. If you look at the volumetric response, I think that similarly with fundoplication, you know, and multiple rapid swallow, there's some synergy between those metrics and what we see with the rack pattern. But I'll tell you, if you have a rack pattern, you're probably going to be okay. And we've got multiple studies now that suggest that. So I think as a screening tool, yeah, but I don't think it's going to supplant manometry and what we get from manometry, whether we're looking at reflux or dysphagia.
The question was more global, was a combination of your FLIP and the mucosal integrity, all measured in the endoscopy suite.
I guess yeah, I mean, you know, it's hard for us to say, Prakash and I right now, because we are somewhat blinded to most of the data. You know, and yeah, it would be nice if we could spare patients or a good portion of patients who have negative results to undergo a catheter down their nose if we can. So if we can, and I think that's where the strength of FLIP and mucosal integrity will have a major role if they turn out to be what I think they will, that we can stop people from getting those studies who are going to be functioning. And then we can concentrate on the people who we actually really have to define. And I think that really gets back to the heart of Lyon with the conclusive and inconclusive diagnosis. I think there was a lot of thought that wanted to create categories where if it was normal, these people were normal. They should never get an operation. They don't have reflux. If they're abnormal, these are the people that, you know, we would put into research trials as GERD and we would consider sending for fundoplication. The stuff in the middle, we need a lot more work on. And I don't think FLIP and I don't think mucosal integrity will address those people in the middle.
I think I completely agree that the problem are those people in the middle. The two extremes are easier. Do you think that FLIP can get an equivalent to the peristaltic reserve as a prognostic value for anti-reflux surgery?
You know, we've got a paper, actually two papers now, but one is focused on peristalsis. And I think we have the opportunity now with FLIP in particular to really get at work and power of the esophagus. And you can do this with FLIP because now you can look at displacement and force. So I think there's a possibility that this can give us a little bit more information, because really what you're looking at is the propulsion in the esophagus enough to open up the EGJ? Because when the EGJ is relaxed, it's not open. You still need a mechanical force to open a relaxed EGJ. And that's essentially what the
fundoplication. I mean, in
but
the context of fundoplication,
you will be able to determine a level of work that is being generated in power in the esophageal body that you'll know that it could overcome potentially a 16 bead lynx, a Watson fundoplication. And you might say, this is not enough work or power for a Nissen fundoplication. So this is someone I would be nervous about. And that's, you know, I mean, that's high end, but I do think there is some potential there.
All right, Ronnie, if you agree, I think that we ended with the selected questions that we had, and I left one for the end to open the discussion of the panel, and that is the following. There is a Lyon consensus 1.0. Let's say, what do we need to get the Lyon consensus 2.0? What are we going to do in the next couple of years to have this Lyon 2? And this is the last question open to the discussion for the whole group. Prakash, can you start?
Let me start. I think Lyon 2.0 is already in our minds. It just needs to be translated into action, and COVID didn't help. See, the original plan was a 5-year plan, and that we were going to have a discussion at Ascona, which was supposed to have happened this year or last year. Now Ascona dates are published now, thanks to Mark. In a year's time, a little over a year, we'll be in Ascona. So I think the real in-house or in-room discussions can start in earnest at Lyon too. Now, there has been progress, but there is one area where we need more information, and that's the on PPI pH thresholds, on PPI pH impedance thresholds. And I think that is an area where there isn't a whole lot published as of yet. Hopefully we'll have more data and we'll have more outcome studies to review. In my mind, probably have another 2 to 3 years before Lyon 2 will be published. And we probably have to take a leaf out of the Chicago 4.0 book in following methodology, because the methodology that was utilized for 4.0 was very equitable, was distributed very evenly around the world, between genders, between countries, between neurogastroenterology societies, and the use of evidence, use of independent reviewers looking at it. And so I think we'll have to move forwards in a more structured manner for 2.0.
Okay. Any other suggestion for 2.0? Ronnie, you have some complaints and concerns. What would you like to change?
So first of all, I don't have complaints. I have concerns.
Okay, sorry.
But I think it's a work in progress. I think it's a holy work. So I do believe that this is something that it's important to come up with proper diagnostic metrics that can help us to make the diagnosis of gastroesophageal reflux disease. I do think that we're going to see more and more changes in how we diagnose it. And I do agree with John that we're moving slowly into the endoscopy suite in making the diagnosis. And I think we will see more of that. What I'd like to see is part of Lyon 2 is reassessment of Lyon 1 and see whatever things that have been proposed there, like some of them that I mentioned, should be reevaluated, like we've done with other consensus meetings, and see if they have any value at this point, now a few years down the line, and being really bold about changing some of the concepts that have come up in Lyon 1, which I think are based on little evidence or are confusing in clinical practice.
John?
Yeah, I think 2.0 starts as soon as 1.0 ends, right? I mean, you realize that nothing's perfect. You try to make something very good, but there's always issues. And I think there was a lot of disagreement at Lyon 1. There was a lot of people arguing, and I was surprised that there could even be a manuscript that came out of that, because there was a lot of discussion, because it was expert opinion. But I think that what we can probably do for 2.0 is reconcile some of the discrepancies among the technologies. One of the reasons Prakash and I started this NIH grant was really to compare all of these particular tools, and unfortunately COVID did slow that up. But I do think that looking at these predictions, like what Tahir said, I mean, maybe we can do some of this stuff with manometry that's reflux related. We do need better standardized, values across the board. And I think some of the work that, you have been doing, Daniel, and with Prakash and Eduardo, these large group studies, looking at interpretation and normal controls and getting a better sense of what those are all going to help. But, the problem is that there's just we don't have good thresholds to really push people in the right direction. And I think, we start at the extremes what is definitely not reflux and what is definitely reflux. And we just have to concentrate on that middle group and at least give probabilities. Like, okay, you're probably normal. You're probably reflux, and I think we may have to kind of shift our benchmark or our goal to maybe providing the best thing we can, which is probability, and not really saying, yeah, I'm going to send you to surgery because your 24-hour pH study is 6.2%. There are so many other factors that go into that probability prediction with machine learning and AI now, that maybe we can feel more comfortable about these diagnoses. So I don't think we should set the bar too high, though.
Any other comment from the group?
Got one quick comment. Obviously, the Lyon consensus is talking about the diagnosis of GERD. And there's wonderful progress being made by all your data on the diagnosis, but there are some patients who are more difficult, and it's perhaps where the data on PPI medication is helpful. So the patients who have the diagnosis of GERD, but also have symptoms, and correlating a lot of these atypical symptoms with the GERD diagnosis is sometimes not so easy, as you know. So there's a little bit more to just making the diagnosis that they have the syndrome, but whether or not the actual symptoms of which they're complaining are related to that is helpful. That's a difficult situation, and studies on PPI, I think, will go a long way to addressing that.
I would like to add relatively close to what Jeff was saying, that the phenotypes that we are using at this moment, the esophagitis, NERD, hypersensitive, and functional heartburn, are there, but the real relevance of these phenotypes is continuously discussed. And even their existence is discussed because of the lack of specific treatments and outcome studies for each of them. And I think that we need to get out of this, to solve this discussion somehow in the years to come. It is not possible that we are using phenotypes of which we don't know if they are real and if they are relevant and how to treat them. So in this in-between conclusive and normal are these phenotypes, that, and we need to try to understand them better. So I think that Mark will close this session. Before he's doing that, I want to thank you all for your participation at late hours in the night in Europe and early in Australia. And I hope to see you in person soon. Bye-bye. Mark?
Thank you very much.
Thank you, Daniel. Thank you, Ronnie. Thank you for the whole faculty that's up early or late. I thought that was an excellent discussion. I think there's so much work to be done looking at the detail of the thresholds. I think the idea of symptom association, which was touched on by many people, including Taher, with the high-end AIM analysis, is really one very important aspect of all of this. So there's lots of work to be done in the detail, but just to take one step back and look at the big picture, which John Pandolfino was talking about, I think that we shouldn't be afraid of the possibility that the future of functional GI measurement is in the endoscopy suite. On the contrary, there's so much functional GI disease out there that if we can be in the middle of the gastroenterology unit, where the action is in the endoscopy lab, where most of our colleagues love to be more than anything else, we're going to pick up so many more people who need our care and attention, the specialist investigations that we've been talking about. There's going to be no concern here. We're not going to be out of a job anytime soon. And on the contrary, many people stand to gain. So with those thoughts in mind, once again, thank you to the chairs, thank you to the faculty, and I hope to see you all in Ascona 3 on the 1st to the 6th of May 2022. Good night, good morning, and goodbye.
Bye-bye.
Thank you.
Bye, thanks.